All right, welcome everyone. My name is Kara Kaikini. I use she, her, hers pronouns, and I'm the Executive Director of the Maine State Breastfeeding Coalition. Before we get started with the webinar, I wanted to make a few announcements. First, I want to let you know that for future reference, you can find our recorded webinars on our YouTube channel. That you can, if you have your phone ready to scan that QR code, you can get to it that way. We'll also drop that in the chat box as well. So we are planning some excellent webinars for the rest of 2024, and we'll be sharing that information soon. And we're not able to offer CEUs at this time, but we can offer a certificate of attendance if that is helpful. So we'll be sending you an evaluation after. There is a QR code here. We'll drop the link in the chat box as well for you to fill out that evaluation. It's great to receive feedback about your experience. And then we will send you a copy of this certificate for you to add your name to. And please save the date for our next educational webinar on April 4th. You can register as of last night. We had this live up on our Eventbrite and on our website. This will be all about supporting breastfeeding through disasters. So Jennifer Russell will be joining us from Tennessee, where she passionately researches and presents on the impact of natural disasters on breastfeeding dyads. And Bill Gwindon is joining us from he's the Mass Care Coordinator for Maine's Emergency Management Agency, where he'll be speaking about what emergency preparedness and management looks like in Maine and what nursing parents need to do to get help in emergencies here. So stay tuned. You can register for that now. We also have our June webinar planned, which we'll be sharing out soon, and welcome any suggestions for future webinars as well. And just a reminder that our webinars have been offered for free. We are a small nonprofit who operates on the generosity of donors and sponsors. So we want to thank our annual patron partners for their support: Acceleron, Soft Corner Midwifery, 207 Pediatric Dentistry, Brandy Rogers, Maine Health, the Barbara Bush Children's Hospital, Let's Go, and Martins Point Healthcare. So we also appreciate donations so that we can continue to do the work that we do, sending out educational opportunities like this, newsletters, hosting our networking meetings, and creating workplace support toolkits. So know that every drop counts, and please consider making a donation here today before you leave the webinar. We'll put that donation link in the chat box as well. And we can always use more folks to help us with this work, so donations of time are also welcome. And again, welcome to our February educational webinar, and welcome to Paula Norcott for being here today. Paula is the co-owner of Maine Mother and Company, a perinatal resource center in Brunswick, Maine. She's also the lactation program director at pumpspotting.com and the breastfeeding educator with Maine's Perinatal Outreach and Education Consultation Services. Paula is a lactation consultant with over 23 years experience serving feeding parents. She got her start in this work as a peer counselor for WIC in Plymouth, Massachusetts in 1999. She worked in a fast-paced hospital setting for 5+ years. Paula currently works in private practice in the infant feeding tech world and consults for both the state as well as a well-known pump company. Frustrated by how nipple pain is brushed off and how slow weight gain is blamed on feeding parents, Paula has made it her mission to help these families feel confident in their plan and their ability to feed their tiny humans with a mental health first approach. When not helping other families, Paula can be found at home with her husband and at least a few of her 5 children, likely drinking good chai. I've had her good chai, it's amazing. Knitting and obsessing about when the next Percy Jackson episode will be released. Yes, I hear that. So thank you so much, Paula, for being here. I will turn it over to you.
Awesome. Okay, let me share my screen and get myself oriented here. Okay, so this is a mini sort of compressed version of what is actually become a 6-hour course that I now teach through the Perinatal Outreach Program at least a couple times a year. So if you're interested in hearing more, I suggest you get on the Perinatal Outreach Program's email list. so that you can get these invites. When we teach it through the state, it's also free, and it comes with 4 CEUs. We expanded it to 6 hours because people had so many questions and we had such great conversations. We wanted some extra time for case studies and all of that. So if you're interested in that, reach out. Okay, so we'll talk today about, we'll do a quick review over the first 3 days. I kind of tend to divide the first few weeks into day 1 to 3, which is very often with at hospital births in the hospital, and then what happens after they go home. So we'll do a quick review of day 1 to 3. We'll talk about weight loss and slow gain. We'll talk about pain and or damage with latch, and then we'll have a Q&A at the end. You are welcome to put questions in the chat box as we go, and we'll try to go through them at the end when we have time. So just a few quick facts. So the Center for Disease Control and Prevention, the report card from 2017 found that 84.1% of mothers ever breastfeed their infants, 25.6% breastfeed exclusively for 6 months, and 35.5% are still breastfeeding at all at 12 months. So we start off great, and then we very quickly dip down. I think we can all agree that one of the biggest factors in our rates in this country is lack of paid family leave. But there's other stuff too, for sure. So according to a study published in Obstetrics and Gynecology magazine, women with breastfeeding difficulties were at a higher risk for postpartum depression. It appears that support was protective, especially in cases of moderate to severe pain with feeding. So this is a quote from their study. And then bottom line, breast milk saves health systems and taxpayers over $1.6 million annually. According to Medela, breast milk reduces risks of 4 of the most common and costly childhood conditions in the first year of life. Reducing these costs not only benefit the parents, but also the employer, as they're often the highest per case costs for Medicaid and commercial insurances. So human milk has a huge impact on our community as a whole. And that's why we need to be working to fiercely advocate for families to feed their babies this way if that's what they want. Okay, so we're going to jump right in. So key points from days 1 to day 3 for, hold on, I have to move everybody's lovely faces, for a healthy newborn. So day 1, gold standard is about 6 feeds in the first 24 hours. Babies tend to be very sleepy. We're talking, all throughout this talk, we're talking about healthy full-term newborns. Anything else is kind of in a totally different category. So goal of 6 feeds, babies are super sleepy in the first 24 hours. They're born with that wonderful brown fat to get them through. It's a great time for parents to kind of focus on rest and get those 6 feeds in. Night 2, I think the biggest thing to be aware of in the second 24 hours in a typical situation is cluster feeding. I put cluster feeding plus hormonal peak. Most babies will cluster feed night 2. There's also a hormonal peak for the feeding parent, which very often means fussy baby or very hungry baby and crying feeding parent. I like to warn parents that this is a possibility so it doesn't blindside them, but that it's also totally normal. That cluster feeding, it has a huge impact on that milk coming in or that big increase in volume that we typically see between day 3 and day 5. On day 3, we're looking for appropriate stimulation, which is typically 8 to 12 times per 24 hours. How many times depends on the situation, the baby, the parent, if we're putting baby to breast, if they're choosing to exclusively pump, if they're pumping for some other reason, that it's all very nuanced, but that's the big goal is 8 to 12 sessions of stimulation. That might be a baby latching, that might be pumping, and in some cases it's hand expression. And then day 4 to day 5, milk typically is in. I always say it like this because you have colostrum from 8 to 10 weeks gestation, and this is just what people have always sort of called it. It really is just this shift to more mature milk or transitional milk and a big volume shift for most people. And one of the ways we can tell, and we'll talk about this today, is the suck swallow pattern changes. So, and then this is here because what often also falls in this day 4 to day 5 is their check at their pediatrician. And that is relevant because they're going to look at weights and make a feeding plan to, based on that. And what they really need to know, and what parents need to be letting their pediatrician know, is that whether or not their milk has come in, because that should impact the plan. Okay, so now I just want to go over briefly what ABM, or Academy of Breastfeeding Medicine, suggests for the following. These are their volume suggestions for supplementing babies in the first couple of days. So hours of age. So in the first 24 hours, if a baby needs to be supplemented, they should be supplemented with about 2 to 10 mLs. So it's important to note the range and not to automatically think we need to start at the 10 mLs. We can very often start small, and based on what our concern is, increase as needed. But these are very, very small volumes. So, and then in the second 24 to 48 hours, we're looking at 5 to 15 mLs or milliliters. 48 to 72 hours, 15 to 30. 72 to 96 hours is 30 to 60 milliliters. Okay, so now we're going to talk about what volumes look like. So this is not an exact science, okay? It very much depends on the baby, the situation, the reasons that we're feeding babies, or we need to know volume. This can come into play if we're looking at how much we need to supplement a baby, which we'll talk about in a little bit. But just a general overview of what babies are typically taking, I think, is helpful because it changes so rapidly. Okay, so these volumes, suggestions, and ranges are based on about 8 feeds per day. And then I put in here as a side note that most babies, and we're talking babies getting predominantly human milk, okay, max out between 25 and 30 ounces per 24 hours. That happens typically around 4 to 5 weeks of age, okay? So, and I think this is relevant. One of the things that I talk about a lot, if anyone's familiar with what we call the K-calorie per kilogram algorithm. So it really is math based on how many calories we think a baby needs by their weight. And the tricky thing there, and I can read it to you, is that according to that type of algorithm, 15-pound baby would take about 36 ounces of milk per day. And the reason that that is tricky, and it just continues to go up, is that that isn't actually the way parents' bodies produce milk. A person producing 36 ounces a day is not really typical. So what's interesting about breast milk is it adapts based on the baby's needs. And so the volume typically stays the same from 4 weeks till they're taking so much solid food down the road that their volume actually decreases. Now, obviously, this is not a perfect science. There are babies who are going to take a little bit more than 30 ounces. There are babies who might take, their range varies greatly day to day. They are human beings, right? So, and this is also per feed. And what I also like to remind people, because babies are humans, is that sometimes they want macaroni and cheese and sometimes they want a granola bar, just like us. So very often, especially if we're feeding at a body, those volumes can vary greatly feed to feed, okay? So this is based on 8 feeds per day. Most babies max out between 25 to 30 ounces per 24 hours. And these are the recommended volumes, and look at the ranges. They're huge, right? And the easiest way that I look at it is typically by week 1, a baby's taking 1 to 1.5 ounces per feed based on 8 feeds a day. By week 2, they're taking 2 to 2.5. By week 3, they're taking 3 to 3.5. Isn't that cool the way the math just coordinates? We don't have to think so hard. By week 4, they're taking around, 3.5 to 4 ounce bottles, typically, if they're being bottle fed, or what we see when we do a pre and post weight with a baby. Appropriate weight gain for newborns in the first 3 months of life is 20 to 30 grams per day average. Okay, so when we're looking at what a baby should gain, that's gold standard. Some people will say 15 to 20, 15 to 30. That's actually how I was taught, but the Academy of Breastfeeding Medicine recommends 20 to 30 grams per day average. And that's also relevant because often you will hear parents say that they've been told their baby needs to gain an ounce a day, which would be 30 grams per day. And that's actually not the standard for breastfed babies. This is relative as we move forward. Will a bottle break a baby? No, a bottle will not break a baby. Will complicated plans break parents? Potentially. And so as I talk through when we supplement, how we supplement, why we supplement, keep this in mind. I've been in private practice for a really long time. I've been in practice for a really long time. I have shifted the way I do things based on maternal mental health, based on the parents' mental well-being and what will help them continue to work on feeding their babies. I also like the underlying bottom line here is that parents feed their babies the way they want to and should not be pushed to do anything else. So we're talking a lot of times here about families whose goal is to exclusively breastfeed or give exclusive human milk to their babies. And that's sort of what these guidelines are based on. If families don't want to do that, it's totally their choice and we can still support them. The bottle piece is key because there's a lot of other ways to feed a baby. And if a family wants to syringe feed their baby, if they need to supplement, fine, great. If they want to cup feed their babies and they want us to teach them to cup feed their babies, wonderful. It has been my experience that after 2 to 3 days of syringe feeding or cup feeding, families are totally overwhelmed and exhausted, and we can lose them. And so a few years ago, I shifted to doing paced bottle feeding. We used to talk a lot about nipple confusion. And what we now know is that nipple confusion doesn't exist. Babies aren't confused. They're smart as whips, friends. So what we have determined is that the big issue with giving a baby who's breastfed a lot of bottles is that they can develop flow preference. And what I sometimes compare it to is if you had the opportunity to have takeout food for every meal of the day and you didn't have to pay for it, would you do it? And I know I would because it's easy and it's delicious. And babies are the same way. If we make those bottles super easy and they get lots, they can very well be like, I'll just wait for the easy game to show up. So paced bottle feeding seems right now to be the key to getting babies to go back and forth from breast to bottle, okay? Complicated plans can break parents, and I've seen it over and over again. I have seen families syringe feeding babies 3 ounces in a 12 milliliter syringe. Do you know how long that takes? Their whole day, every minute of their whole day is feeding a baby. They're not eating, they're not sleeping, and they will either break or quit. And we're trying to prevent both of those things. Okay, so now I want to talk about when you are looking at babies. So I know we have some visiting nurses here. I know we have some people from WIC. I sort of designed this training for if you're working with feeding families, how to assess a great feeding post day 3 to 5. So we're talking once that milk is in, for the most part. And the biggest factor that I look at is the suck swallow ratio. And that is literally how many sucks to a swallow is this baby doing? I'm going to show you a video of a typical 1-to-1 suck swallow pattern, okay? It takes a lot of practice to get to really understand this. And what I recommend for people who are just learning this part is to shadow a lactation consultant, right? Spend some time in a clinic where you're seeing lots of normal newborns. It takes practice to really see it and understand it. Some babies have loud swallows and you can hear them, and they sound like soft little k sounds. And some babies are very quiet or silent swallowers. So the video I'm going to show you doesn't have sound on it. There's not supposed to be sound. I want you to look at the baby's throat and jaw and see if you can spot the swallows. So we'll probably watch it twice and I'll point them out the second time around. It's real quick, so it goes by super fast.
The end of the feed.
Oops, hold on. Okay. Oh, I do.
Therefore, you will not see your breast slipping back and forth under baby's lips or see milk.
Okay. Look at that jaw. Okay. So I want to just back it up a little bit so we can see it again. Hold on. Swallow, 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 swallow. So not every suck here is a swallow, but this baby is predominantly 1-to-1 suck-swallow ratio. So it's a little bit tricky to see exactly what you want to be seeing. It takes practice to spot the suck-swallow breathe ratio, okay? I mean suck-swallow ratio, sorry. Okay, so why does that matter? Because what we're trying to determine if a baby is having some struggles, or we just want to assess based on a feeding observation, if things are going great, we need to understand the suck swallow pattern, okay? And what we're looking at is milk transfer. And if you have a baby who isn't gaining appropriately or has other symptoms that you're concerned about, it's very often called the supply problem, okay? You'll hear this a lot. They have low supply, low supply. Do people have low supply? They absolutely do. They totally do. What we need to determine is it a parent problem or is it a baby problem? And if babies aren't moving milk effectively and efficiently, the parent's body does not get signals to increase that volume. And so it can be a transfer issue that leads to a supply problem. And what frustrates me in this industry is everything is sort of blamed on the parent. And so really understanding and being able to look at what a baby is doing and how it's impacting a supply is really valuable. So let's go over some symptoms to look for if there's a concern with a baby. So symptoms to look for that might be a concern is not a pretty consistent 1-to-1 suck swallow ratio. And this should be in the first couple of days once milk's in, their feeds are quick because they're essentially chugging and funneling. Milk is coming at them so fast, they're like glug, 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 glug. So in those cases, those feeds can sometimes be a little shorter, 10 to 15 minutes, okay? As that volume requirement goes up, which we saw in the full feeds volumes, right? As that volume requirement goes up, babies should be able to suck, swallow, suck, swallow, suck, swallow through a letdown and beyond. Okay, so 10 minutes into a feed, we should still see a pretty consistent 1-to-1 suck swallow pattern for most babies. What you would see instead, which is concerning, is a lot of butterfly kisses, which I like little short sucks, a lot of long pauses, and you're not hearing or seeing lots of consistent swallows. At the end of a feed, if we're 15, 20 minutes deep, those butterfly kisses are pretty normal. Babies are usually finishing up. But in those first 8 to 10 minutes, and sometimes a little bit beyond for some babies, they should be pretty consistent with that suck swallow. Very sleepy babies, babies who won't wake up to be fed, especially in the first 2 weeks. Babies need to be prodded because they burn through their calories really, really quickly. And so if we don't wake them up pretty consistently, they can actually start to not have enough calories to wake up. That's why that phrase, never wake a sleeping baby, should only be applied post 2 weeks of life, okay? Once a baby's back up to birth weight and we know they're doing well, that can shift a little bit. So very sleepy babies, short and frequent feeds. They're feeding for 3-5 minutes and they're having like 12, 14, 16 feeds a day, or really extensively long feeds. Babies are nursing for 45 minutes to an hour. Every 2 hours, there could be a problem there. Very fussy baby who won't be put down. This is one that can sometimes be missed. I see this a lot where like they're okay, but no matter what I do, they're really upset. Like screaming, high-pitched screams can sometimes indicate hunger. High weight loss or poor gain after the milk volume is up. So babies can lose up to 10% of their birth weight before that milk comes in. That's really pretty normal. We don't love them to lose much more than 10%. I have absolutely seen very normal newborns who are at 11% on day 4, but milk's in, they're chugging, they're gonna gain weight by tomorrow, okay? But if they're not consistently gaining appropriately, or they've lost more weight. I saw a baby this week who was at 10.7% weight loss at 2.5 weeks of life. That's not great. We need to intervene there. So what tools can you use as an average person, like a visiting nurse or, Maine Family CLC or CLC, a doula? What can you look at and what can you do to help these families immediately? So I have pre and post weights with a question mark, because if you don't know how to do a really solid pre and post weight, you should not be doing them. Pre and post weights should always be done in grams. They should always be done on a scale that's accurate to 2 grams. And there's a pretty specific way to do them. We talk about it in the big class. Probably not going to get in too much detail here, but what I like to explain to families is that a home scale is not a scale to do pre and post weights on. A $200 to $300 scale probably isn't going to cut it. My scale that I use here is a $1,600 scale. Is that outrageous? Well, yes, it is, but it is very accurate. You can tell a family that they can do some pumping and feeding back. What that looks like depends on the family's specific needs, okay? So if we're seeing babies got high weight loss, say babies at 11, 12%, milk's in, you could say for the next 24 hours, you can pump 2 or 3 times and feed back what you get. Or you could just have that baby weighed again in 24 hours. But if it's long-term, sometimes pumping does a couple of things. It boosts calories, and sometimes we boost calories on an infant, they feed better, and it's giving additional stimulation to that parent. The other piece is that if parents are concerned about weight loss, and I assure you that nobody wants their baby to thrive more than parents do, and they're nervous or concerned, seeing volume go into their baby with their eyeballs on a short term can make them just relax and concentrate on feeding their baby. It's really stressful to these families. Pumping instead of latching, protect the supply. And we'll talk about this when we talk about pain too, and other reasons to supplement. There's another note down the bottom. It says why I no longer use triple feeding as a tool. So if you are in this world, you know that triple feeding means we nurse a baby for 15, 20, 30 minutes, and then you pump for 15 minutes, and then you feed back that milk to the baby. And I see a major flaw in this, and that's that we've totally forgotten about peeing and eating and sleeping for the parents, right? This is cute for about a week. After that, it's absolutely overwhelming and exhausting. And I always use this tool, but what I have figured out in my practice, and remember, I'm in private practice, so this is not within the first 4 days in the hospital, but in private practice, I have found families to be super overwhelmed by triple feeding. So what we do instead here, and something that you can talk to your families about if there are situations happening that are just not looking great, is that they could pump instead of latching. Some people will, I tell parents, latch that baby once a day, do lots of skin to skin. You can do recreational feeding if you don't have pain or damage. But the big goal here is to protect the supply while we figure out what the heck is going on. Because if we don't end up with a full supply, this family does not have the option to exclusively breastfeed their baby if they want to. That is the single most important factor in success, is that full supply if that's what they want. Get them an IBCLC now. These tricky cases are really sort of out of the scope of baseline lactation training. So if you're a CLC or a CLE or a CLR, your specialty is normal patterns, okay? So if this is a little out of your scope, pull in an IBCLC. Let's get this family the support they need sooner rather than later. Okay, supplement as needed, but only if needed. And that's, again, if a family wants to supplement, they can. But formula specifically can be a very slippery slope, especially when we're talking about supply. Replacing feedings with formula, sometimes we have to. Sometimes we have to, and the baby needs that. But not every time we supplement a baby with formula, we should be having that parent do some pumping, okay? Because what we're losing out on is the stimulation at the breast that tells the body to increase volume. We're replacing that with formula instead. I'm really happy to talk more to people about why I don't use triple feeding in my practice anymore. You can always email me at paula.norcott.ibclc. I think it's in the chat. If you have more questions about that, because it was an absolute game changer for my families, and I don't think I'm ever going back. Okay, so the other big red flag that pops up in those first couple weeks that you all on the ground with these families are gonna see is nipple pain and damage. This picture here, and I know it's shocking, is an actual patient of mine. And this was at 8 weeks. I didn't see them until 7 weeks postpartum. So this is after a week of implementing a major plan and doing lots of healing. I'm happy to say that this baby's almost 2 and still nursing because we figured out the problem and healed. But this is a major red flag. And I think there's a lot of misunderstanding about pain and damage with latch. Pain beyond the first 30 to 60 seconds of a latch is not normal. Is it common? Sure. Is it normal? No. A little in the beginning, especially with a first-time parent, totally normal. And then they should kind of say, okay, not too bad. I feel tugging. They shouldn't feel pinching or friction like sandpaper throughout a feed, especially if they're feeling that and you're looking at the latch and you think this latch looks gorgeous. Especially if the latch looks beautiful and there is pain, there is likely a problem. Compressed nipples, so when the nipple comes out of the baby's mouth, if it's flat, if it's lipstick shaped, if it's creased, if all the blood is drained, if it's white, there are a couple reasons for that, but more often than not, that is nipple compression between the hard palate and the tongue, okay? Nipple should rest way at the soft palate. Run your tongue along the roof of your mouth. Feel in the back where it gets squishy. That's the soft palate. That's where the nipples should rest. If it's between the hard palate and the tongue, it's getting compressed, and that can lead to pain, okay? Any damage is not typical. If you see mild abrasions on the tip of a nipple, parents say they have no pain. Sometimes they'll say things like, oh, that happened day 3, I was sleepy, I fell asleep, I had a shallow latch, I didn't know, it's not happened since then. That's one thing. But if you're seeing damage, especially, it can be unilateral or bilateral, but often we see matching, like identical damage shapes on both nipples. That is a problem. That is a problem. That warrants an IBCLC. So what tools can you bring these families? A nipple shield. And nipple shields are not rainbows and unicorns. They're a pain in the butt. They're invisible. You put them down, they disappear. Pets really like to eat them. They're one more thing that you have to have when you feed your baby. But what I love about them is they tend to create a really quick barrier for families with damage or pain. So sometimes all we need is a nipple shield families can, continue to feed their baby with their body, and we can work on figuring out what the underlying problem is. It also can, in some cases, be the thing that protects the damage while the nipple is healing, so we can see if that damage comes back. There's no, sometimes babies become dependent on them. I think that's another key piece here, but I haven't really struggled to get babies off of a nipple shield. If we are very patient with them, it happens for most babies. Utilize multiple positions. So you can encourage them, if they're always feeding their baby in the cross cradle hold, encourage them to try football. And what that's going to do is change where the friction goes, so it's not always in the same place. And then they can sort of alternate. Laid back actually presents with a totally different position, and it will just change like a clock on that nipple where that friction is, and can make a huge difference. Pumping instead of latching. If you ever see damage like this, please may you never see damage like this. But substantial damage, these things aren't going to cut it. We had this parent move to pumping instead of latching while we healed the nipple. And a dead giveaway is, oh, pumping doesn't hurt, but latching does. And we protected the supply. She nursed her baby once a day, and for the whole rest of the day, they pumped and bottle fed. And then as soon as that damage was gone, we started adding nursing sessions back in. But again, the most important piece is to protect the supply at all costs if this family wants to exclusively breastfeed. It's a lot harder to backpedal on supply than it is to get a baby back to breast. IBCLC now, please find a great IBCLC, set that family up with them. And then the other thing I have here is body work. So we're really lucky in our state where we have lots and lots of DOs, because our medical school here is an osteopathic school. So we have a lot of OMM and OMT in the state, including a huge portion of our hospitals actually have DOs who round in the labor and delivery unit. They're magical. You can also seek appropriate chiropractic care, and you want someone who works on newborns regularly. Chiropractors who work on newborns do not crack babies. They use, essentially, they're all using the same techniques, which are around craniosacral therapy. There's also craniosacral therapists. You want somebody skilled. You want somebody who does this every day, but it can have a huge impact on babies who have a lot of compression in their heads and necks. They tend to have tight, tight, tight jaws. How can you tell? Very often these babies, their ears are touching their shoulders. Their hands are like this. Families will say, oh, they're so strong, I can't even pull their arms out to dress them. That's not strength, that's tightness. Babies who come really fast, really slow, cesarean, we're talking pushing phase, not labor, have forceps deliveries, vacuum deliveries. These babies tend to have the most compression in their bodies. There isn't a ton of evidence for this, and I will honestly tell you that I am very skeptical. I verge on cynical. When I first saw this, I thought it was utter nonsense. And then working in a hospital where we had osteopaths rounding daily, I'm here to tell you it's absolute magic for breastfeeding difficulties, especially pain. We had started to do a study up at Maine Gen when I was there years ago, and then COVID ruined it, so we didn't get to finish. But it is hugely impactful. And if I'm telling you that, it's got to be real, because I really was like, I don't know if I trust this. And now I love them. I call them magicians. Here are just some basics for reviews. So feeding a baby with your body should not hurt. Damage is not normal. Pain throughout feeding is not normal. Okay. Most people are able to make enough milk if demand and supply system is working well. There are absolutely people who have things like insufficient glandular tissue, other reasons, including hormonal factors that lead to low supply. But most people, if the demand supply system is working appropriately, will make enough milk for their babies. That is not 60 ounces a day. So if you have families who say things like, well, I'm only making 35 ounces a day, that is high average. Most people are somewhere between 25 and 30. Support is the #1 factor in feeling successful. And that means from you, That means from their pediatrician, that means from their partner, that means from their community as a whole. This is what has the biggest impact on these families, is feeling supported. Expected weight loss for newborns is up to 10% or until milk comes in, right? So they should typically, they keep on losing, little less each day. Milk comes in, and then typically that first 24 hours after milk comes in, they gain 20 to 30 grams. Sometimes I've seen babies gain 45. And it shifts really pretty quickly for most babies. The latch video we watched is from a video called Follow Me Mom. The first half of that video is fantastic. There's a great visual of what happens inside a baby's mouth during feeding. It's very 1986, just so that you know. And then there's a whole portion on pain, which I show this video at all my feeding classes, but I don't show the second half. I show that beginning with the latch. I don't want them to get in their heads that if they have pain, they're doing it wrong. We address that separately. Affordable Care Act mandates that 6 lactation visits are covered with an IBCLC. So for some people, like we take some insurance. I know there are lots of other private practice LCs in the state that take insurance. Most of the hospitals with a dedicated lactation consultant across the country have outpatient capability where they can see patients. And I know here in Maine, you do not have to be a patient at that hospital to go in for an outpatient visit. Sometimes they're super busy and it can be a little tricky, but if you deliver at Maine Med and you live in Augusta, you can call the lactation department in Augusta and be seen, and your insurance should cover it, okay? And then again, expected weight gain for a baby is 20 to 30 grams per day per Academy of Breastfeeding Medicine. I was trained 15 to 30 grams a day, but this is my favorite. I love this little window, 20 to 30 grams a day average for the first 3 months. And then those are just our first couple of days of supplementing again. Okay, that's a wrap. This is quick, you guys. This is a 6-hour class I teach. We squashed it into a very short period of time. I want to leave lots of room for questions, because what's important to me is that you all get the information that makes the most sense to you. So I am going to unshare my screen.
Thank you, Paula. That was great. And yes, this was an express version.
Super fast.
I
Super
love
fast.
the term express for this as well.
Express, that's right. What
Uh,
questions do you all have? I know this is a lot. What do you see, Kara?
no questions have come through yet, unless I've missed them, but Robin did share an idea that a client of hers had given about painting a nipple shield painting a bright color of nail polish on the nipple shield so that it would be easier to find at night in particular.
Yeah, I know a company called Series Chill started making colored nipple shields. They're big and they're bright, and they actually turn clear with body temperature. They only have conical nipple shields. They don't make cherry-shaped nipple shields, but I keep asking her too. So, but that's it. They are invisible. In a hospital bed, it's brutal. They're just gone.
Mm-hmm.
What else? I saw another comment here. Oh, it's a lot of people here. Look at you all. That's amazing. You can also unmute yourselves if that's easier for you.
You put your cameras on, unmute, and ask if you'd like. I think, there might be some things that Paula said that you've learned something different, or you've practiced something different. And so Paula is more than happy to answer any of those questions that might help you better understand something that you might be struggling with, if there is any of that.
Yeah, I think when you all are on the ground, you're the first line of defense for these families. It's so helpful if you can kind of help them put a Band-Aid on the situation immediately, like especially with pain or damage. Would love to hear more about, my change in approach to triple feeding. Yes, this is a big deal, you guys, because I did it for years. What I do with families who a family that I would have done triple feeding with, and that's usually like babies aren't gaining enough, and often also supply is kind of not really where we would want to be. What I have these families do is I move them to pumping every 3 hours, not more than 8 times a day. Okay. If we don't have substantial damage, I'll have them latch their baby once or twice a day based on how they feel about it. So that baby has good, recollection of nursing out a breast. And I have them pump for 15 minutes about every 3 hours while we boost supply. And part of the reason I did this is because if we have a supply problem, and I mentioned this earlier, we don't know if it's the baby not giving great signals, if it's true low supply. And so, we've been saying forever that pumps are made to mimic babies, and very often babies are more efficient and effective than a pump, except if the baby isn't efficient and effective. And then in those cases, the pump is actually more effective. And I have seen countless times over and over again, we get these families right up to 28 ounces a day. And then we start to baby step the babies back to breast and make sure there's no major issues there. And sometimes they had pain and damage in the beginning, it goes away. And we get their volume up and everything's fine. And sometimes we get their volume up. We know this parent can pump 3 ounces at a session, and the baby can only transfer an ounce. That's a problem, and that's a transfer problem, not a supply problem. Yes, great. Yes, Pam. I think people miss this piece, especially if they deliver in a different part of the hospital, or they have their babies at home, or they have recently moved from out of state with a newborn. Most of our hospitals, if they're not too slammed in their lactation department, will see patients who didn't deliver there, and insurance will cover it. Oops, sorry. Yeah, so that's my thought. I would love to hear your thoughts on triple feeding, because I think this was a big deal for me. It changed a lot. And my parents are much happier. And I hear it a lot, like they sometimes come to me triple feeding and we switch it and there's instant relief in their faces. Like, oh, it's taking 2 parents 1 hour and 20 minutes for every single feed. That's just simply not sustainable. A printout that I can put in front of my computer. Tell me more, Angelica, like what specific things are you looking for in a handout? Because I have a million handouts. Should I give a bottle? Yes. Yes. Parents need rest to function. I do the same in my small practice. Me too. And that was another thing that was a big shift for me. I think slow flow nipples are the priority. My favorites are Even Flow Balance, the Lancino, and the Dr. Brown's. But I tell people, if you don't have a dishwasher, don't do Dr. Brown's. Oh, I don't know why that does that, because they have 10,000 parts. Post the 6-hour class. The 6-hour class is not up yet. We have to plan a date. So get on the mailing list. It's so much fun. We do it in person, 6 hours. When the number one feedback we got on the 4-hour class was we need more time. And that blew my mind that you all want to sit with me for 6 hours. But we have such great conversations. We do case studies. We do problem solving in real life situations. Like, what are you seeing? How can we address that? Hand expression instead of yes. So hand expression doesn't touch a nipple, right? So if you have a lot of nipple damage and a parent can successfully hand express, it absolutely works. And especially in those first 3 days in the hospital, if we've got damage or tender nipples, we absolutely move to hand expression. It works. I usually give them a choice. I teach them both. Some families are like, I don't want to do hand expression, and they want to pump, and that's fine.
I've had families that are more successful hand expressing or more successful with machine, and that's what they end up choosing which one is more successful.
Totally. And that's
Yeah.
why teaching them both, right, is so
Mhm.
valuable, and letting them decide what works for them. Weight gain and milk supply. Yeah. We can come up with something for that. Email me, Angelica, and tell me exactly what you're looking for, and we'll figure something out for sure. 6-hour class is amazing. Thank you, Cynthia. Haka. I love the Hakas. I actually love, there's one that's put out by a company called Lumama, and it's a little bit different. Sometimes the Hakas are so intense that people don't like, it's like uncomfortable, especially if they have nipple damage. The big Hakas, the ones that kind of look like grenades, that style can have really intense suction. And so I like the Haka ladybugs that are more passive. And I like this Lumama Alara because it can be, you can put some vacuum there or you can just use it passively. It has both capabilities and you can actually adjust the suction. It has a little valve on the top. So you can easily adjust the suction by letting a little air in. Oh my gosh, I love it. Thank you, Angelica. It went by super fast. I was like, how am I going to do this in an hour? Cool, cold washcloth to numb nipples. So I tell, like, ice is a great tool. If there's substantial damage, they really, if there's damage like we saw in that picture, Apno is not going to fix that. Lanolin is not going to fix that. Nipple butter is not going to fix that. What we actually used with that family was Meta honey, which is honey that's treated for botulism. The hospitals now carry it, or a lot of hospitals do. It's a game changer. Yeah, anything that works, like what's working for a family that isn't going to cause more problems than help, for sure. What else? What else? What else? Build a stash. Yeah, the Hawk is so great because you can just catch on one side while you're nursing on the other side. Although I could tell you funny stories about how many times I've heard of babies kicking the haka off in the nighttime. I have one family who the baby kicked the haka, spilled milk all over dad's face, and he didn't wake up. And so she didn't tell him till the next day. Yeah, there's like, in the thing with breastfeeding, well, with anything, right, is that the science is changing really, really rapidly, and evidence-based practice is changing really, really rapidly. And a good example of that is the mastitis engorgement protocol. It has shifted in the total opposite direction. And that's something that you all can help with, is letting providers know this, because just last week I had a mom with mastitis and her provider told her heat, extra pumping, and deep massage on the spot, which is the opposite of what we're doing now. It's not their fault. It's just like, I'm not going to give, I have no idea what's happening in the medical world with evidence-based practice. We rely on physicians for that, right? So it changes so quickly that we need all of you to go out there and tell providers when you see them, when you meet with them, if you work in their offices, to like try to stay current and reach out to IBCLCs if they need. All the IBCLCs know this new policy specifically. Okay, looks like that's all your questions.
And I'm trying to find, I'm just looking for that link to that protocol for people to have.
Yeah, we made a handout and I'm happy to share it with people too on it that has a QR code. It's lymphatic drainage is the other piece of the protocol, and Maya Bowman's breast gymnastics video. You can Google it. It's all over YouTube. She just won an award and it's so good. And it's so simple for these families to do. It almost seems too easy to work. It works so well, so well. How soon do I suggest pumping after having a baby? It's so nuanced. So if it's an exclusively pumping family, immediately, like as soon as that baby's out and everybody's settled, they should start pumping every 3. If they're having, and if there's difficulties, that's tricky. Oh, if you're talking, okay, going back to work. I do it a little bit differently. I tell families around 2 weeks. And mostly because families are really anxious to create a stash for going back to work. They want 150 ounces in their freezer before they go back to work. And typically at the 2-week mark, babies are back up to birth weight, right? Feeding patterns are pretty well established if things are going well, and they can add in 1 pump a day in the morning and start stockpiling. The other thing I do at 2 weeks is I encourage families to do a practice bottle once a day. I have seen no babies refuse a breast because of a bottle ever that we couldn't fix. So many bottle refusing babies that we actually have a bottle refusal handout here because it's constant and these families are terrified. I have babies getting fired from daycare because they won't take a bottle. If you are a working parent, you can't afford for your baby not to take a bottle. So a practice bottle is literally once a day, 1/2 ounce every day, because smart babies, it only takes 2 or 3 days for them to be like, I'm not doing that. So every day, at least a little bit. It doesn't have to be a full feed. You can still stockpile all your milk. And some families will move to pumping twice a day. Oh, that's a great question, Allie. I am not a fan. First of all, it's outrageously priced. Let me grab a bottle and show you why I don't like it.
And for those of you who are watching the recording, you didn't see the question come through in the chat, and I'm just realizing we should be restating those questions. I think
Oh,
Paula
yeah,
you've
sure.
done that.
Okay, so look at these two bottles. This is the Tommy Tippy. This one's Tommy Tippy. This is the Even Flow Balance. See the shape difference? So the Emulate is a bottle that you mold a breast. You mold your own breast is basically, it's designed on the parent's actual breast. It still has a nipple like this. So it's a breast at rest, right? And what happens with this type of bottle is babies end up straw sucking because there's nothing for them to hold on to. See, they just end up slipping like this. Whereas this is like a breast at work, right? So when the baby's on there, they have a nice deep latch and it's pretty wide. So the Emulate, parents are bombarded by marketing in the baby world, and it's a huge industry, you guys, and it's like predatory for these poor families. And so I often tell people, like, it's a $4 bottle with 3 parts, and it's my favorite. The Lancinos are great. Dr. Brown's are really easy to come by. They have a true slow flow nipple. The shape is a little bit different, but if the baby's all the way to the ring, it's decently wide. It's still better than what's the one that everybody likes? Oh, the Comotomos. Do not like, nothing to hold on to, nothing to hold on to. They just end up like this, straw sucking. And I think that's probably where nipple confusion kind of came in initially.
All right, so last question. I see Allie put one more in. We need to wrap up, but happy to hear you answer what pacifiers you recommend for breastfed babies.
Yes. So what I tell people is when picking a pacifier. So first of all, there's one on the market called the Ninny. It's got a nice wide base. It's $14. So it's just not attainable for a lot of people. It's kind of shaped like this bottle. It's nice and wide. Other than that, I tell people when they're picking a pacifier to look at the shape of the pacifier and ask themselves if they want their nipple to look like that. And if the answer is no, don't give it to your baby. The new shape that I'm seeing everywhere is like bulbed at the end. I don't want my nipple to look like that. So just round. Hospitals usually use Jolly Pops. It's a great shape. The Sassies are a great shape. The Soothies, those brands, and they're usually easy to come by. The orthodontic shape, that's only comes into play if your baby still has a pacifier at a year. Babies really only have that suck drive from 4 to 6 months. And that's when a pacifier is really useful. After that, it kind of becomes our crutch. I'm here to tell you I've had the crutch. I get it. But pacifiers really, their best use is between 4 and 6 months. And if you get rid of it before 6 months, you won't have trouble getting rid of it. Allie, we can hang out together. You had great questions.
Thank you. I'm almost 20 weeks, so I feel like I'm bombarded with like just everything, and social media is like a blessing, but also not. So I'm like, what do I want to do? What route? But I appreciate everything.
Of course, reach out anytime.
Thank you, Paula, so much for all this great information in a short period of time and for answering all these questions. Thank you, everyone, for being here. We'll be sending out that evaluation by email, and any other resources, Paula, that you want to share, I can send in that same email as well.
Okay, great.
Great. Have a wonderful day, everyone.